Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod.
Hello, everybody. This is Josh and Adam. Welcome to another Doctor Journal Club podcast. And today it is my privilege to introduce Dr. Adam Sadowski, who is now 30 years old as of today. And he's already beginning his gradual decline.
Yeah, like I was saying before, the bones are aching, the sarcopenia is hitting in. I got my DEXA scan going, colonoscopy scheduled, and my skilled nursing facility picked out.
Yeah, I'll never forget certain things from naturopathic school. One of them was my anatomy professor yelling at us. Someone was like giving her a hard time, and she was like, "Oh yeah," she was questioning her authority basically, and she was like, "What do you know? You're not even fully ossified." I thought that was hilarious. And then conversely, I just remember my physiology professor being like, "Yeah, pretty much in all organs that matter after 30, you're just in decline. Sorry, guys."
Yeah. At least my brain is done developing, I guess. So I guess this is
it's done developing, but it's reached peak brain. Now you're on the way down.
Peak brain. Oh boy,
I think so.
Which is actually kind of fitting for the topic we'll be talking about.
Yeah.
How's your life been? Any updates?
Well, I think birthday's a big one. Hold on, don't jump off that one just quite yet, because I think it's a big one. Are you what are your plans? Are you going all in? Did you sleep in today? What are you doing today? Anything fun to celebrate?
No, I didn't sleep in just because I'm so used to getting up early that I think my natural clock just kind of woke me up, even though I kind of like laid there. I was like, okay, let's see if we can sleep in. And I was just kind of like restless in bed. I was like, all right, let's just get on with the day. But no plans, nothing in particular. I'm not like an event guy. Like I'm not like, oh, I have to do all these things and like
totally
round up all my friends and go do these. I'm like, no, I like Netflix and ice cream, and I'm really happy. But what I do plan on doing today is it's a deadlift day in the gym, so I got that, and then I think
don't herniate or anything like that. Just remember your age when you go in there.
I know, yeah. So I'll be doing that, and then probably right after that, go for a 30-mile bike ride. Bike 1 mile per year. It's not the first time I've done it, so it's not like like a huge accomplishment or anything like that. But
that's good.
I think it's fitting. It'll be good, and part of Ironman training anyway. So
you're at 30.
Swimming earlier this week, so I'm due for either a bike or a run, and I don't want to run 30 miles. So
yeah, no, you don't have to worry about that. I think what is 73 is what a half marathon. So that'd be like
kilometers,
13.
right?
What's that?
73 kilometers.
No, I think it's the weirdest thing, the way they do like metrics for this stuff. So they call it Ironman 70.3, and I think that stands for the number of cumulative miles. But they always report swims in meters, and marathon is usually in miles. So that's like
it can't. Well, if it's a 70.3, unless that's different from the full Ironman, because the full Ironman is a 112-mile bike ride.
Yeah, so 73 is a half Ironman, but that's like what most people do, because even that you have to be like superhuman to do. And I don't even understand the people that do full Ironmans. But yeah, I think 70, that makes sense. Then I think it's the 70.3. But anyway, so worst case scenario, you need to run 13.1 miles after like a 2-kilometer swim, 50-mile bike ride, something like that.
Something like that.
Yeah. Anyway, so it's good. It's good. But you got in the pool. That's good. So that's
Mhm.
awesome. You're getting your swimming in, which is great. Yeah, man.
Also,
That's
one
awesome.
thing I
Yeah.
don't recommend is if you're gonna go for a swim,
Mm-hmm.
don't do it before a very full, busy clinic day without having any sort of goggles and swimming in a chlorine pool, and then not really bringing a lunch with you, because not only will your eyes hurt and be blurry, but you'll be so hungry the entire day.
Yes. I've actually been trying to experiment with like how to fuel during longer swims, because like my swim practices now are about an hour, and normally I'd do like a goo or something at 45 minutes if I was on a bike or a run, and I'm flagging at the end of the swim. And so I don't know. So I see people with water. I see people with like, I don't know if they do goo or anything like that, but yeah, I have to think about that. If you come up with a good idea, um, let me know. But anyway, cool. So, what's new in my world? Not much. I think same old, dude. Yeah, I think we're
Handling
good.
kindergarten okay?
What's that?
Are you handling kindergarten okay?
Yeah, doing better. Although like he comes home really happy, and that's a good sign. But then like you get these stories about like, oh, like this kid pushed him, or this kid did this, that, and the other thing, and you're like, well, that doesn't sound right. And then you don't hear from the teacher, and then you'll also hear things like, oh yeah, they let them watch Minecraft all day in school, and I'm like, well, I know that's not true. So like I don't know, I don't know what's real or not. He once told us he went to the moon for like lunch break. So, it's hard to get a sense of like, and you don't want to like make too much of a deal about it to him to like over obsess, but then you also want to make sure if it's real, like it's being investigated. So I don't know. So like there's like weird stuff like that. So like I think he's like trying to adjust to, 5 days a week, other kids. I think they roughhouse a little bit, but yeah, I don't know. It's just kind of regular old life stuff, I suppose. Um, but yeah, no, doing well otherwise. And what was I going to say? Oh yeah, so today for our pod, so I have I every once in a while. So when you're an EBM doc, right, you have these dreams of like patients that are so excited about evidence, and you're going to have these like numbers needed to treat conversations and talk about power and stuff like that. That never happens. And anytime you try, at least in my experience, you try to bring up anything about EBM or even numbers needed to treat, you get that sort of like look in their eye, and they're like, I don't know what you're talking about, but what would you do in my situation? Right. And so, but every once in a while you get a patient who's like just really well read. Usually they're in the medical field, and they're another doc coming to see you, or other medical professional, etc. So anyways, long story short, I had a patient ask me about a paper. She's on PPIs, proton pump inhibitors, because she has Barrett's esophagus. And unlike sort of conventional wisdom on PPIs, which is like, well, we don't really know if it's beneficial, I think it's actually very beneficial. Like the new meta-analysis, I think, which has not been updated in the guidelines, is pretty clear. I don't think it's equivocal. I think it is beneficial, even if the magnitude of effect is small. I think the effect is real. So anyway, we can get into that. We've got a video on that, and all my pontifications on that as well. But anyway, so she's on PPIs. But PPIs are not my favorite med, and she's very concerned about dementia, runs in her family, and then sort of her major, major concern from a values perspective. And so, we've had these multiple conversations about weighing the pros and cons, and it's just been eating at her. And so we've been talking a lot about it. Anyway, so she found this really great paper that she wanted me to read and kind of review for her, and I actually see her later today, so it's perfect timing. And kind of give her my thoughts, and we can talk about it. And it was a very heavy mechanistic paper that's essentially it's like enzyme kinetics in silico. So basically like computer based models of enzyme kinetics, and way over my head, nothing that I normally look at. You have to be like a physicist of some sort, or I don't know, molecular chemist or something, for that to be your field. But it was interesting, and what it proposed essentially was a theoretical mechanism about how PPIs could be causing dementia through the acetylcholine pathways. And for a long time, there's been this back and forth evidence on are PPIs associated with dementia? Are they not? And you have these back and forth studies and these back and forth meta-analyses, but no one's really come up with a good mechanism until this paper. And so this paper was pretty influential, and it sort of led to a lot of things. So I read the paper and I found it interesting, but I'm not a big fan of hypothetical stuff anyway. And so I was like, well, I'd much rather find a large scale observational study or a meta-analysis to see if there's actually something there. And I kind of remember a paper in BMJ years ago that was influential for me, but then I couldn't find it. I think, Adam, you were like, didn't we do a journal club on this? And I was like, I thought we did. I couldn't find it. Were you able to find it?
No, I was not able to find that. But I do know that for one of our journal clubs affiliated with the Gastro A&P, we did talk about PPIs and Barrett's esophagus. So maybe it had to do
Mm-hmm.
with that.
Yeah,
But
maybe that's
I
what we were
wasn't able
thinking
to
of.
find anything. No.
Okay. Yeah. So anyway, I couldn't either. And I was like, I know. Anyway, it doesn't matter. So it was a good opportunity to go back to the literature and find something new. And there was actually this new 2023 meta-analysis on the topic that was informed and influenced by this mechanism paper that the patient brought to me. And basically it was like, okay, we have this new study that suggests a mechanism. We have these question marks in the literature. Let's do a really high quality meta-analysis and try to answer this question. So that's what we're going to talk about today, essentially, is the meta-analysis on the association between PPIs and dementia, not cognitive decline, not mild cognitive impairment, but dementia specifically.
And I think that was
Yeah.
something that was interesting was in this paper that they actually specified that of like, hey, we were actually interested in this hard outcome of incident dementia, not just a change in cognitive scores. So on our last podcast, we kind of talked about that with the MIND trial, where it wasn't looking at incident or new onset of clinical dementia, but more so just the changes in cognitive scores. So this
Mm-hmm.
is a lot different. This would be like, okay, is there an association with, let's say, in this instance, heart attack versus a change in your cholesterol?
Mm-hmm. Yeah. Yep. I think that's true. And so it's sort of like analogous to our surrogate versus hard outcomes that we're always talking about. And also, and I'm not really major in this field, but what I could read from the introduction is there seemed to be some question about the transient nature of mild cognitive decline too, and how malleable that is as opposed to dementia. And so just another reason to really focus in on that hard outcome of dementia. So I agree. Cool. All right. So let's jump in. So basically, introduction here, pretty much what we talked about. PPIs are extremely common. That's true. And they can be very effective for reflux in particular in the short term. The problem is, and this is not just my opinion as a naturopath, but lots of docs' opinions, is most of the research on this is for short-term use for like reflux-like symptoms. But the way it gets prescribed is you go into a doctor's office, you say anything about your abdomen, they give you a PPI prescription, and then that's it. And then you're lost to follow up. And I see you 10 years later and you've got like gastric, hypertrophy or something crazy. And you've been on it for like a decade plus. And you're like, well, no one told me to stop and it's over the counter. And so, and that I just see that all the time. And so there are potential concerns with it. And I think the biggest issue that people have is if it was used appropriately, it wouldn't be much of an issue. The way it's used with the potential side effects have us, a little bit concerned. And then, of course, with something like Barrett's esophagus, again, we'll link to the video on the website. We have a whole course actually on Nancy Eck approved continuing education course on that. But that's not what we're talking. We're talking about that here. But what we want to know is that associated with the dementia risk or not? Okay, good. Alrighty, so here's the other thing. What they said is, meta-analyses in the past had been back and forth. There is an association, there isn't an association. But the biggest limitation that they noted was two things. One, the largest study on the question was relatively recent and hadn't been included in the meta-analysis. So that in and of itself is a good rationale. And the other is that for technical reasons, no one pooled different outcome measures. So, your meta analysis might report things in odds ratios, risk ratios, hazard ratios, and it's technically complicated to combine them. And so what meta analysts end up doing is just combining the ones that all share the same metric, right? Even though they're all trying to describe the same thing just in different ways. And that really limits the ability of the meta analysis because you're excluding a lot of data. So what they wanted to do here is use these are like very highly skilled meta-analysts. One of them is like the chair of epidemiology at the major university. They're very, very skilled methodologists. And so basically they said, well, we know how to do this. And so they that was sort of the main recommendation as well, is can we combine these across outcome measures? Any questions so far?
Nope. Pretty standard.
Pretty standard. All right, so let's jump into it. So the basic setup of the meta-analysis, I'm not going to spend a lot of time with. It was pretty standard, and they did a good job. They sort of ticked all the boxes on a high-quality meta. One thing I would say is they did really state-of-the-art methodology. So for risk of bias assessment, they used things like the risk of bias 2 scale from Cochrane. They used the Robbins I scale for non-randomized trials, which is also sort of high quality, very newer anyway, risk of bias assessment. So they really are using top shelf, cutting edge methods on this one. So that impressed me as well. And then they did some other cool stuff, like, for example, and actually some cool stuff that I had a little question about, and we might disagree on this one. One is they excluded studies if the risk of bias was viewed as critical. So there was one study that they ranked as critical according to Robbins I, and they say according to the recommendations of the developers, they excluded it from the meta-analysis. Like, it just was not included. I think it was in the qualitative summary, but not the quantitative.
Okay, so I think that that's something that's important to recognize, is that they didn't include it in the actual analysis, but they did include it in the overall review, and they did make note of it, which I'm okay with, because if you have something that's at critical risk of bias and you're going to be doing, let's say, a sensitivity analysis anyway of like, hey, let's exclude these studies and see what studies without a high risk of bias show, I would kind of prefer that, because, why would you want to analyze something that's at a critical risk of bias when, it's going to influence the results? And if someone's not actually reading the meta-analysis and just looking at the forest plot and trying to quickly find results, and they don't recognize that, that can be misleading or harmful. So I'm kind of okay with that.
Yeah, I figured you would. You're stricter than I am. I'm the way I've always been taught to do it, and the way I'm comfortable doing it, is your primary analysis is like everything, and then you do your sensitivity analyses. And a high risk of bias study, you would just take it out in a sensitivity analysis, right? And say, well, the best studies say X, but you're excluding data points by doing that. So I was a little uncomfortable, but what I would agree, it's definitely like a reasonable position. It seems like it was an a priori excuse me, a priori decision. Sorry, there's a little frog in my throat there. So, I mean, that's okay. And they do have
analysis, Josh. It's not going to hurt you. No need to cry.
Yeah. Well, methods get me, man. They really get to me at the core. So anyway, so that's one thing. I guess the point there is they're a little stricter than I would be, but not unreasonably so. Let's see, what else did I want to say? They like we talked about, they converted different outcome measures. Everything else is pretty good. Then they did a whole bunch of very fancy stats and methods in their bias analysis, the vast majority of which I was not familiar with, and spent way too much time going down like a bunch of method rabbit holes tracking them down. But they all seem legit, very interesting, and I'm not sure really what they add to the narrative of the study. So that was kind of one interesting piece. One thing in particular that they did do is something called a prediction interval, which I was not familiar with. Have you ever heard of that before?
I haven't heard of it, but when I was just kind of looking through the paper, it kind of my take was essentially, okay, what other confounders that were not sort of perhaps accounted for, what degree or what magnitude of effect would this sort of possible confounder need to be to have any sort of impact on the results? Because all the studies that were included were observational.
Mm-hmm. Right. Yeah, I think that was some of their bias analyses, but that wasn't necessarily the prediction interval thing. But yeah, that's right. In some of the sensitivity analyses that they ran, they're like, okay, if we are missing a covariate, how huge would the effect have to be to really push things? And it had to be pretty big, which would tell us even if we're missing some, unaccounted for covariates, it's probably not a major player. So I thought that was kind of cool. But yeah, this prediction interval thing was kind of new to me. So they report the results in terms of a regular, effect size with a confidence interval, which we're very familiar with, but then also a prediction interval, which was kind of neat. So let's, I guess we should talk about that super briefly now, just really fast. So I was like, what the heck is that? Is that even legit? Like, all my radar went off. And so I started searching around, and there's all these papers, and I couldn't make sense of it for a while. And then I went to Twitter. And this is why I love Twitter, because with all the issues with Twitter, like, you can reach bigwigs really easily. So I was like, whatever, I'm just going to tweet at the head statistical editor at the BMJ and just ask him, what does this mean? And how is this different than a confidence interval? And amazingly, he responded within 30 minutes and was like, oh, it's really important. Oh, and by the way, I wrote a paper on this that would absolutely clarify this for you. Here's the link. And I read it, and it was amazing, and it totally clarified it. And I'm now completely convinced. And then I, kept on doing a little bit more research, and Ioannidis, who's one of my heroes, has a whole paper on I think it's literally goes like this. The title of the paper, and this is classic Ioannidis, right? They have great titles. A plea for routinely presenting prediction intervals and meta-analyses. So he's obviously in support of this as well. So anyways, all right, this is kind of neat. So in sum, super fast, what the heck is it? So you meta-analyze things, you combine them together. You are basically giving yourself a best estimate, a fancy average of all the different studies to best estimate a true effect, right? That's what the effect size is in a meta-analysis, right? You with me so far? Okay. The confidence interval basically tells you the range of probable values that estimate is. So I say this causes dementia increases the risk by 50%, but it could be anywhere from 25% to 75%. So my best guess on the effect is 50%, but that could be anywhere between 25 and 75. So one way to think about it, and this is Ioannidis' language, which I really love, is it's the most the probable range of values that estimate really lies in. The true effect lies in. The true average lies in. Now that's important. The true average. That makes sense if you are meta-analyzing identical studies, right? If it's a fixed effects meta-analysis where every single study is done in the same lab, with the same dose, with the same intervention, with the same population, same length of study, etc., you would do something called a fixed effects meta-analysis where you just basically do a weighted average. When you don't have that, which is 99.9% of the time, you have heterogeneity. You have different patient populations, different dosages, sometimes different meds within a medication class, like classic or antidepressant meta-analyses, right? You use whole different sorts of antidepressants. There's value in that depending on your question, but you are introducing heterogeneity. So an average is not a true average of an effect of a particular drug at any population. It's the average of the entire class of medications being studied. Now that could be useful for policy decision making, and even for clinicians if they want to say in general, are antidepressants useful and should we pay for them type of thing, right? That would be useful. But if you're a very particular patient in a very particular population, you might want to know actually what the weighted average is in your population. And the problem with the confidence interval is it is too narrow because it's around this average effect. A prediction interval basically widens that based on the heterogeneity between studies and says in the next study that was ever done in this grouping, what would be the range of effects you might see? And that's going to be a lot wider. And so essentially that's the idea, and that's closer to reality. So they're both valuable. It's just what you're getting at. If you just want to know the average of the class, confidence interval is totally fine. If you want to know, okay, if they do another study on this question, what are the likely ranges that we'll see? That's going to be your prediction interval. So that's sort of my layman's attempt of explaining that. Does that make sense? Did that make any sense? I don't know if you're muted or I just totally lost you.
No. I thought I unclicked the muting, but I guess not. Yes, it makes sense, and there seems to be sort of this Bayesian element to it of when you were initially describing, because in my understanding, well, I'm not even going to try to explain Bayesian models, just because that is very complex, but there does seem to be a bit of a Bayesian element to it with regards to this.
Maybe. So I mean, it could be. I think it's just a different way. I don't think they're using Bayesian stats. I think they're the sort of classical stats, frequentist stats. But at least what I thought initially when I saw that, the equivalent to confidence interval in Bayesian is what? It's credible interval or credibility interval or something like this. It's also CI and it's analogous to a confidence interval. That's what I first thought that they were talking about. But this is a totally different thing, this prediction interval thing, and it is based on frequentist stats, I believe. But I think the idea maybe of looking at, well, I don't know. Yeah, I don't know if I'm following the Bayesian argument.
Okay. Well, before we lose all of our followers who are going to turn off the podcast, can we get into this, the clinical component of this and do
Sure.
what's going on?
This is the danger. I got so excited when I saw this paper. I was like, "Ooh, all these new methods." So anyway, thanks for going down that rabbit hole with me. And if you're still listening, it's basically completely meaningless to the results of the paper. So disregard everything I just said, unless you're a methods nerd. Look, the thing is, we don't do this for money. This is pro bono, and quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential, and there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession and integrative medicine and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause. Okay, so what did they find? So the total here, let me get to the actual meta-analysis here. So the total meta-analysis had 9 studies that looked at the effect of proton pump inhibitors compared to non-use on dementia. So there was 9 of them that went into this quantitative meta-analysis, 7 of which had sort of a high risk of bias when they did their analyses. So 2 are going to give us the most useful data. When you combine all of them together across like over 3 million people, so this is a lot of people, these are large observational studies. When you do that, the effect size is, the relative risk is 1.16, so 16% increased risk, but the confidence interval is anywhere from 1.00 to 1.35. And so what does it mean, Adam, if your lower bound of your confidence interval touches that line of no effect?
I view that as no difference.
Right. So it's basically analogous to saying the p-value is above 0.05, and usually it's kind of thrown out. And that's how the authors looked at it. Now I'm going to circle back to that in a second. So when you meta-analyze them all together, you get this 16% increased risk, but it's not statistically significant. And then when you look at the better quality studies, there's just 2 of them though, the relative risk is now 1.54. So now you have a 54% increased risk, and it is statistically significant. And your heterogeneity goes away. So one of the problems with meta-analysis is if the heterogeneity is too much, that's measured by I-square, and essentially it was really high with the standard meta-analysis. And so what you're supposed to do is explore that and see if you can figure out your apples from your oranges. And when they do that and they just look at the high-quality studies, that I-square essentially goes to 0, which tells us these are 2 very homogeneous studies. They are reasonable to combine together, you might argue, and we see a 54% increased risk. That's statistically significant. And the test of interaction between the high quality and low quality studies is statistically significant, further reinforcing the idea that the bias might be driving some of the results. Interestingly, in the opposite direction, you would think. Questions at this point?
I think we need to put a pause on, or at least be cautious when we say high quality studies. I think, these studies are, relatively speaking, of higher quality than those that were at serious risk of bias, because when you're saying these high quality studies, they're still at moderate risk of bias, of
Mm-hmm.
which there's only two. In the
Correct.
studies that were at serious risk of bias, there were seven of them.
Correct.
So I do think that, if we're going to say high quality studies, they're still not high quality, and they're limited to only two prospective, or well, they're not. They may not even be prospective cohort studies, but it's limited to two observational studies. And maybe you'll get into this, but what we do see is that there's different types of observational studies, and within this meta-analysis, they did show that. The observational studies of a little bit higher, or more rigorous methodological approaches also did seem to show an increased risk with the use of PPIs.
That's
However,
right.
the heterogeneity was still rather quite high. And
Mm-hmm.
then, going back to, the estimate of effects, where the confidence interval was a 1 to 1.35.
Mm-hmm.
One way that you can kind of look at that is if you had kind of like a cupboard full of Tupperware,
Uh-huh.
and the Tupperware is like leaning out, and if you open it, all the Tupperware will come in. So you just quickly like close the door.
Okay.
That's how I kind of view it when it hits that 1.00. The estimate of effect is leaning towards there being a statistically significant association, because you're exactly at 1.00. So that's kind of like the cupboard or the pantry being full of Tupperware that's about to spill out. And so I don't know. That's just kind of like the correlation that I kind of have in my mind, is like how to view that, of like, well, there could be something there. If we're going to be, very rigorous about it, we're going to say that there's no effect, but it's kind of like this pantry where either the Tupperware will all fall out and fall on you, or if you quickly just put your hand up, you can kind of stop it from collapsing.
um, well, I don't know that I follow the analogy, but now until my dying days, I'm going to look at that line down the middle of a forest plot. And it's going to be the edge of a cupboard door. And
Yeah.
it's like, if it crosses it, those dishes are falling out. But, that's actually, so let's talk about that. That's actually the issue. So in summary, like that's basically the study's results, right? Is that they find a 16% increased risk. It's not statistically significant. The better quality studies, and your point is very well taken, by the way, and I should have highlighted that. You're right. These are observational studies. So when I say better or higher, and maybe I misspoke, I don't mean high. These are not as good as randomized controlled trials. Observational studies can only be so good. So when we combine the better ones compared to the worse ones, we see it's more likely to have this effect of dementia. So that's sort of evidence weighing towards caution, but it's not definitive by any means. So I apologize if I misspoke there, and thanks for pointing that out.
Mhm.
But that's basically the take home: 16% increased risk across the board. If you look at the better quality studies, your risk goes up maybe to 30%, maybe to 50%, and those are statistically significant. And my major beef with the study authors, because I thought they did a great job and it's technically very advanced, the narrative is terrible. It doesn't read very well. It's about as clear as mud. But the way they spin the results, I just don't agree with. I mean, they basically say there's no effect. And I'm like, I'm looking at the same data and I'm saying you are barely not statistically significant. And we know we need to be cautious about these threshold effects, these arbitrary thresholds with p values, and that we can't be overly obsessed with them. And we're literally kissing that threshold, that line in the sand. And what we should be looking at is, in my opinion, holistically at the data, which is like, there looks like there's a 16% increased risk. It might be as high as 50%. We're not sure. A lot of the better quality studies are statistically significant. I don't know, man. Like when I look at this, I'm like, there's evidence for concern and caution in my book. It's certainly not, oh, the result is right on the middle there. There's nothing
Well,
doing.
I don't necessarily agree with that. I don't think that they said that outright, of there's no association. That they did state in their conclusion that there's no clear evidence. So, like you said, it's clear as mud that they increase the risk of dementia, but it does not mean that there is no clinical implication for use on the risk of dementia, and this should always be provided with a planned treatment strategy according to the appropriate guideline recommendation. And then because of the discrepancies between primary and sensitivity analysis, more research is needed. I think that
Don't
that's
you
a
think that's
very
just hedging? That's hedging.
no. I
That's
think that
hedging your hedge. That's hedging
no.
the hedge of your hedge.
I think this is the issue in
Did that even say anything? That's like
that's
milk toast,
you're
warm
gonna let me talk.
tea, everything.
I think this is the issue with society is that everyone
Oh
wants
boy,
a
here
hot
we go.
everyone wants a hot take, and everything has to be black or white. Everything has to be on the extremes, and nobody is willing to kind of settle on the sexiness of the gray zone that really exists. Of hey, we don't know, and like you can try to spin this to say there's either no effect, or you can spin it to say that there is an effect. But I think that their conclusion, even if you think is more of like a politically correct answer, is kind of boring, is they're hedging their bets, or whatever you want. I still think that that's the correct conclusion of like there could be evidence supporting risk of dementia, but maybe not. We really don't know. I think that that's the correct takeaway. And like, hey, use these as they're planned according to guideline recommendations, and have a plan with their use, not necessarily just go to Costco and buy a tub that has a year's worth of PPI on it when maybe you don't actually need that, because there could be associated risks of harm in doing so.
Yeah, that's fair. I think probably what we're getting at here is like when you have a result like this, like you said, you can spin it either way, and a lot comes down to how the authors do that spin. I look at this data, and I'm like, I don't necessarily want all my patients on PPIs if they don't have to be. And what you pointed out is, well, that's kind of what they're saying. They're saying you should be judicious about its use. There's a potential risk signal here. But I'm like, well, I would have been stronger in my language, and you're like, well, I think their language was good. And so I think this underlies, this is one thing they didn't do that I think would have been valuable, is if they would have done grade and used the grade language guidance, that would have taken the spin out, right? Or the temptation to spin, because they have very a priori language. Like if grade level is moderate, you can only say it may lead to, if it's low, you can only say it's uncertain, or whatever the languaging is. And that doesn't give you the option to kind of
Mhm.
spin here. And so maybe that's kind of what we're bumping up against.
Yeah, and I think that that's one issue of highly technical papers, is that you spend so much time trying to explain your methodology and statistical analyses, and trying to be so precise and accurate that you kind of lose the forest through the trees in what are the clinical ramifications of this.
Yeah, I think that's really true. And I think a lot of the art in like a good manuscript writer is that balance between sexiness and a narrative, but without spin. Like you want to spin, but not too much, right? If that
Mhm.
makes sense. And so I think Ioannidis is a good example of that. He always has great titles. You want to read the papers, they're clearly written. Dr. Riley, who sent his BMJ paper on prediction intervals, I mean, I was just so confused when I was reading stuff on this online. And then when I read his paper, it's like, that is so clear. It totally makes sense to me what this is. And there's some people that just really have the ability to clearly explain things. And
Mhm.
when I first looked at this paper, I was like, wow, like this is a major paper, great methods. Why was this not in the BMJ? Why was this not in JAMA? Why isn't it in this sort of, I mean, it's a good journal, but second tier journal. And now I understand. It's the narrative, it's the writing. It's just, it isn't a clean story. And I think that is important to journals. And maybe that's a problem that it's important to journals, but I think that is sort of a soft skill in science, the ability to kind of tell a story without getting lost in the weeds. Because they did a lot of fancy stats, but I don't know that it added much to my understanding of the data.
Exactly, and that's kind of my point. Is like, okay, we did all this fancy stuff, didn't really get much of an answer out of it. If anything, made the clinical decision even more confusing.
Yeah.
And you can kind of now, it may even cause to issues from a clinical standpoint of one person can come and say, hey, look at this paper, it showed that there was an increased risk, and then someone who's perhaps maybe more well versed or just disagrees for whatever reason could be saying, well, I disagree with that take because of reason XYZ based on these statistical models. And so I think that just in that there could still be there could be two camps, one saying, oh, there's nothing to worry about, and another one that says, no, there is something to worry about, and so you haven't really achieved anything.
Right. And that kind of irks me too, because I feel like, there are 9 major studies, over 3 million people. And to just walk away and be like, oh, we need some more research. Like, I don't know, like that does a disservice, I think, to like the millions of dollars and all the people who put their data forward for this. And I know, I feel like just sort of punting in research and saying, well, we just need more research. At some point we have to be able to make statements. But I understand like the spin risk, and that's why I like having those guidelines in front of me. So those guide rails, so I don't go off the rails, because I can get pretty excitable about things like methods, for example.
But I think there is
Yep.
also danger in just being like, hey, we have to make a statement because we don't want to increase the risk of dementia because
Right.
we don't have good treatment for it. So it's not like, hey, will this result in increase in bloating? Like, big whoop if you're bloated, right?
Okay, so you're making my point, my friend. Think about that. You've got zillions of doses of this stuff out there. It's over the counter. Everyone and their mother is on PPIs for decades for like stomach aches, essentially. Not always. Like Barrett's, totally legitimate use. And I'm stricter than most of the MD guidelines on that. But most of the people out there using PPIs, they use it like Tums, right? And it's prescribed. It's not their fault. It's being prescribed like Tums, right? If there's even a signal, shouldn't we be concerned? Like, I don't know. I just, it's the context that matters too. And I feel like the context maybe warranted a stronger statement. Now, granted, they're not guideline developers, they're methodologists, but
Do you think it would be appropriate then to say, hey, maybe this is evidence to show that maybe perhaps most medications shouldn't be readily available over the counter?
well, I think this one, I think that makes sense to me. And I think, so the counter argument is like, well, we've already told the doctors that this should be used in a certain way, which is acutely with follow-up care if you don't respond, right? And further investigation if you don't respond. And they're like, so this is basically just reinforcing that. And that's because, there's a risk signal, may or may not exist for real. There's lots of benefits to it. But, do follow the guidelines, right? Which is what they're saying, which is what you're saying, which is what everyone would say. And yet the doctors are not. So whose fault is that? It's not the fault of these poor methodologists that are trying not to spin their data and trying to sound like scientists. But like, that's just frustrating to me, because I know that the prescription is just going to continue for this stuff, and it's not going to, change people's practicing behavior, unfortunately.
Mm-hmm. Mm-hmm. But I mean, and as frustrating as it is with statements of like, hey, more research is needed, I still think that that's something that's valid until you have a study where it's just like, no, we have a grade, high grade evidence with these consistent effect estimates, low risk of bias studies. Adding more to the literature is not going to to provide much more evidence, right? I think.
Yeah.
And I think, going back to our love of GLP-1 agonists, I think like we're kind of there with those of like,
Did you get your tattoo yet?
of like, hey, I think we're kind of like, we can probably stop with all these GLP-1 diabetes trials because we have these consistent
so obvious.
effects. We know what's going to happen. We have a consistent, effect size estimate. We have multiple meta-analyses basically showing the same thing. Like, I think that is fine when the evidence is so clear for benefits and harms that it's probably fine to stop and kind of like, hey, we've kind of exhausted this. But for things where it's a lot more trickier and there's still a lot more that needs to be kind of teased out, I do think that it's fine to say like, hey, more research is needed. Now, that being said, I don't think it gives us kind of free reign to then do whatever we want with the research. I think that the questions and the funding for that additional research really needs to kind of be pinpointed to like, okay, what specifically do we need more research on?
Yeah.
We don't need more like mechanistic, maybe rat model stuff, because unless we're trying to really tease something out. But okay, now we need more studies on on dementia trials and PPI use and stuff like that. So I think, okay, more research is needed, but we also have to be really resourceful with our resource allocation into, okay, what exactly do we need more research on? Don't just make a blanket statement of more research is needed.
Yeah, I think that's true, and I think that follows, more recent Cochrane guidance, which is don't just say more research is needed, like you're saying, say specifically what it is, and also I think it's a different audience, right? To researchers, you need to say more research is needed, and this is what you guys need to research, and this is what funders should fund. But for clinicians, like that doesn't help us, right? Like we still have patients in front of us and we're not going to wait 40 years to make a decision. And so like I feel like it's a different audience. And for that audience, it's like, well, we've got 3 million people, 9 studies, and the data is pointing in this direction. Like make of that what you will, type of thing. Um, so that's interesting. And Gordon Guyatt tweeted yesterday about guidelines and making recommendations when there's low quality evidence. And they had done some sort of survey that was basically like, should we even be giving guidelines recommendations for low quality evidence, or just leave it up to the providers and the patients, right? Because that's essentially we're saying like, well, we don't really know, so it's kind of up to you. But the survey results are, at least for clinicians, they're like, no, we still want guidance. Like we still want to know which direction you're leaning, right? Like maybe it's reasonable to disagree with low level evidence, but we still want the guidance. And I think maybe that's what I'm saying is I think clinicians need that guidance. I don't know if it's CYA or if it's because like we just want to know like, okay, what are the experts where are they leaning anyway? And if I know this field well enough to disagree rationally, like that's fine. But we do want guidance, right? Like that, I think that's very clear. And so I get frustrated with the milk toast conclusions from some of these papers.
But I think that is guidance with like low quality evidence and having that discussion of saying like, hey, we don't know. Unfortunately, like with as modern as medicine is today, there's still a lot that we don't know. Based on the best available evidence, we still don't know, and here's what the evidence is showing. So I can't fault you if you want to go forward with the treatment. I can't fault you if you don't want the treatment. And here are the risks and benefits that we know about thus far based on the available evidence. However, dot dot dot.
Yeah.
It's kind of everything's kind of up in the air. So if you want to take some time to think about it, that's fine. And I think that that's something that we should be having conversations with our patient, because I think as clinicians we're too quick to want to try to fix something and try to give something to our patients when maybe we doing nothing might be the best approach.
Well, I mean, maybe, but think about this patient. So this is a real conundrum for me. And I have to see her later today. I'm not sure what I'm going to tell her because, on the one hand, she's got Barrett's, and I believe, even though the guidelines don't state this, I believe there is pretty convincing evidence that she should be on PPIs for that Barrett's, even though the magnitude of effect is relatively small. So I'm more confident in the quality of the evidence for a low effect size, right? On something that's important, right? On the flip side, she has family history of dementia. She's terrified of dementia, as we all are, and it's a major underlying concern for her. And my take of this study is there is a risk signal there. So but it's low quality evidence and lower quality evidence than the PPIs, but the outcome is worse, right? Dementia. So that's a tough one. I mean, that's a tough, and so it's going to come down ultimately to her decision, and we're going to have this conversation, but that is an interesting balance. It's not so clear to me, like what I would do in her situation.
And I think that shared decision making at its absolute finest of like, we I don't know, right? And I
Yeah.
can't fault you on your decision leaning either way. Here's the benefit, here's the risk, here's the evidence. Here are your values. So this is kind of like that three stooled approach of my clinical expertise, what the evidence is showing, and patient values, and all of those three need to be respected and kind of taken into account. And you make a decision and you move on.
Yeah. Yeah. It's maybe it's just shared decision making can sometimes be uncomfortable because it speaks to the fact that there's not clarity on the issue.
Hmm.
And when the outcomes are real and significant, you don't want to make the wrong decision. But yeah, no, that's a really good point. I think that's ultimately what we're talking about. So hopefully we modeled this okay for everybody. And if you have any follow-up questions, please let us know on Dr. Journal Club. Any last minute thoughts, Adams, before we sign off? I've got clinic and you've got are you going to clinic today? Are you taking the day off?
I've got clinic today, yeah.
Okay. All right. So we're going back into the trenches. Any last minute thoughts on your birthday before we say goodbye?
Last minute thoughts are that we've got videos planned for the rest of the year on the Dr. Journal Club website. So
the mothership.
The mothership, yes. For members of Dr. Journal Club, you will be having videos on a variety of topics, some of which we have not discussed on the podcast at all and won't be discussing on the podcast. So if you are interested in some of those topics, they are only available on the Dr. Journal Club website. So tune in on those, and we've got videos planned for the rest of the year. So you will be all set to go there. And then otherwise just follow us on social media.
Yeah. And maybe you can help weigh in on a debate Adam and I are having. I really want to put swag on the website. Like, I think we should have Dr. Journal. We should have mothership t-shirts, coffee cups, like, I don't know, cool stuff. And I know that's a bit of a distraction. We don't have time for this, but like, I can't stop thinking about it, Adam. And I think it's because like one of my favorite podcasts, Advisory Opinions, started like selling swag with like all these inside jokes. And I just think that's so cool. And I have a stats guy that I follow on YouTube who has like a Stats Quest. He doesn't support the show. He should, but he doesn't. And I've got a Stats Quest shirt. Like, I don't know. I just think it's kind of fun. You kind of show your, your support for a little podcast startup and all that jazz. And you've got this sort of community feel. But I don't know, Adam, you're not feeling it, right?
I'm not feeling it, no.
Not feeling it. So weigh in, dear listeners, particularly. So here's a little publication bias issue. So if you agree with me, you should go to drjournalclub.com, leave a comment, or email josh@drjournalclub.com. If you agree with Adam, just be lost to follow up. Yeah, lost to follow up. And maybe we will do an Eggers regression and visual inspection of the funnel plot later. We shall see.
You are such a nerd.
I am. And maybe that could be one of our swag things. You are such a nerd, drjournalclub.com. All right. Take care, everybody. Happy birthday, Adam. See you later. If you enjoyed this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook. We're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.